Hi everyone, I might get started if that's all right. So, my name's Manini and I'm covering mood and anxiety disorders today. So, this is obviously a really big topic, and there are some areas that are more high yield than others. So, I will be focusing on those, but I do have slides outlining sort of everything that you should know about mood and anxiety disorders. Just heads up, it's too hard to cover in 45 minutes. So, we'll see how we go. So we're looking at this part of the pyramid. So I'm sure you guys know by now with this, whenever you're thinking of differentials like in an OSCE station, for example, always, start from the top and work your way down. So I'll be going through depressive disorders, bipolar, anxiety, OCD, and other related disorders, and then trauma and stress related disorders. So depressive disorders, there's quite a few. So we'll go through major depression and premenstrual dysphoric disorder, essentially. With the others, I just want to make a point that with anything that says other specified or unspecified, the other specified usually refers to something else that's not a medical condition that's known to cause their depression. So we're really obvious in the question. And with unspecified, you just won't have a cause, but they'll have all the symptoms that fit the criteria. And that's sort of across the board for everything, which is why I've decided not to repeat them for every sort of subset of mood and anxiety disorders. So this is just a bit of a timeline in general to get your head around. So with a major depressive episode, usually lasts about 2 weeks. And within that period, you should have an adequate number of symptoms almost every day for all of that period. If it's substance or medication induced, we'd like to see that the symptoms go for like 1 month at least. Major depressive disorders, 6 months, and then persistent depressive disorders, 2 years. So often in questions, that'll be the way to like differentiate what the diagnosis is, because the symptoms will be quite similar. So with major depressive disorder, there's quite a few risk factors, but the things to think about are age. So quite common in the elderly, quite common in the adolescent population, more prevalent in females. If there's a history of trauma, again, it can be confused with PTSD, but PTSD and depression are quite highly comorbid with each other. So that's something important to keep in mind. Having a family history of depression is a major risk factor. And as well as having low socioeconomic status or any other chronic illness is often associated with depression. As far as what's actually happening at the pathophysiological level, we have lots of environmental risk factors, but essentially it's the monoamine hypothesis. So not enough serotonin is the main thing that we're talking about. But when we look, as you guys would have heard this morning about the pharmacological management, we can also use other medications apart from SSRIs, like we can use SNRIs and MAO inhibitors, and that's because they're all involved in that pathway. So as far as the history goes, MCGCAPS is how I remember everything that I need to ask about. So that's mood. And so I guess the first thing to think about is you need to have one of either a low mood or anhedonia. So you have to have one of those two plus others. So they're there. I'm not going to read them all out, but just another important part of the assessment is assessing their suicide risk, because if they're at high risk of that, that's going to alter your management and you're more likely wanting to send them into the hospital rather than trying to manage them in the community. So there's lots of different subtypes of depression. Again, you don't need to know a lot about those, but what I've outlined here is the major features associated with each type. So if you're asked about that, for example, they're the things you'd be looking out for to help you decide what subtype of depression the person has. So as far as those history questions that I had up earlier, with the DSM-5 criteria, like I mentioned, you need to have 5 or more of those during the same 2-week period. And that should be a change from their previous baseline functioning. And at least one of the symptoms, like I said, needs to be low mood or anhedonia and should last for at least 6 months. So that's what so with psych, I found it's all very criteria and symptom based. So if you sort of get your head around that, it becomes a lot easier to handle. As far as investigations go, again, if we go through our pyramid, ruling out anything organic that could be causing that alteration in their mood. So, could they be anemic? Could that be because of a B12 or folate deficiency or an iron deficiency? Are they, hypothyroid, for example? And, all those others that I've got there. Any other medications that could be contributing to their symptoms as well. So there are a few common ones that come up. I usually remember that because there's a lot of the antis, like antihypertensives, antipsychotics, but just a few to keep at the back of your mind when you're taking a history from someone. As far as differentials for depression go to think about, and make sure you rule them out in your history taking process. So you can have a minor depressive disorder, so that's having less than 5 of those 9 criteria. But still, each episode still goes for more than 2 weeks, but the episodes are more than 2 months apart from each other. Brief depressive disorder, so that still meets the criteria. So you've still got more than 5 of those 9 symptoms, but it doesn't last for the full 2-week period. Dysthymic disorder is kind of like where you don't fully meet the criteria, but it goes for a really long period of time. So that over 2-year period, but not fully meeting the criteria for depression. And adjustment disorder, which we'll talk about a little bit later when we talk about PTSD. And we'll also get to bipolar, and you would have hopefully covered psychosis, but just with schizoaffective disorder, and I guess depression in general, always ask about psychotic symptoms. You can have depression with psychotic features, but it's important to make sure that it's not schizoaffective disorder. And you'll know if it's schizoaffective because they'll have the psychotic symptoms for a 2-week period where they don't have any mood symptoms associated with it, versus depression with psychotic features where they'll have all the mood symptoms all the time, but they'll also have psychotic symptoms. So in terms of management, again, it's very structured. You always think about lifestyle, psychotherapy, then meds, and then anything else you can do on top of that. So obviously we know that there's organic things that can cause it. So treating anything reversible. Sleep hygiene is often really important, especially in the adolescent population. And as far as psychotherapy goes, cognitive behavioral therapy is really mainstay, but some others that can be useful are interpersonal therapy and supportive psychotherapy. SSRIs are your first line medication, usually fluoxetine. There's a few others apart from SSRIs that you can use for depression, such as agomelatine, moclobamide, and reboxetine. Again, it's important to know that these are options, but you'd always start with an SSRI. MAO inhibitors as well, and you can augment antidepressant medication with other classes of medication in the more severe depression. So things like lithium or a second generation antipsychotic could be used, not common, but just something to keep at the back of your mind. The next thing to think about is ECT. So usually ECT is indicated when the depression is quite severe, or if it's melancholic or catatonic depression or has psychotic features. If the patient's quite distressed, if they choose to have ECT and the psychiatrist thinks that's the most appropriate treatment for them, or they've got a really high short-term suicide risk, because we know that antidepressants do take that sort of 2 to 6 weeks to start fully working. Transcranial magnetic stimulation is not used that frequently at the moment. It's still sort of being researched, but it's just another option to know about and keep at the back of your mind. So I guess that's depression as a whole. Sorry, I know I'm rushing through this, but there's a few things to talk about. Premenstrual dysphoric disorder, I'll just talk about quickly. So it's where you have PMS symptoms that start 5 days before the menstrual cycle, and they start dissipating either through it or just when it finishes. It's quite an extensive criteria, and then don't expect you to remember this. If you are asked about it, it will be quite obvious that this is what's going on. But you essentially need one of those top 4 and then one of the bottom 7 symptoms, and 5 of those 11 altogether. And again, like anything else, making sure it's not due to another medical disorder, not due to substances, not, it can't better be explained by anything else. Again, with investigations, ruling out anything else organic that could be causing their symptoms, and also doing hormonal studies, given that we are talking about the menstrual cycle. The management here is, again, quite focused on lifestyle this time. So focusing on diet, stress, and exercise in this setting is really important, as well as CBT. As far as pharmacotherapy goes, it's actually the new generation oral contraceptive pills that are first line, along with psychotherapy. But you can start a low dose SSRI if you think it's appropriate, but you'd always do the COCP first. Second line, you can consider estradiol patches or just oral progesterone, and increase the dose of your SSRI or start an SSRI at this point. And then third line is where you really sort of start having discussions about major options like GnRH analogs, or add back HRT, but that has its own risks like osteoporosis. So they're really last line measures, and hopefully you should be able to get it under control with lifestyle changes and other forms of pharmacotherapy. And again, fourth line's surgery. So then we come to bipolar. So these are all the disorders that just you have a vague idea about that sit under this set of disorders. And we'll be talking about bipolar 1 and 2 and cyclothymic disorder. So sorry, I hope this makes sense, but so essentially up here is mania and down here is depression. What I've tried to indicate is that for bipolar 1, you need to have manic symptoms that last 7 days, or that they're definitely manic and they're detected. So if they're detected before 7 days, but they can be classified as mania, you can still have bipolar 1, but informally the criteria says 7 days. For bipolar 2, it's hypomania, and we'll go through what that is in a little bit, but that should last for 4 days. And to be diagnosed with bipolar 2, you need to have a depressive episode definitively that lasts for 2 weeks, versus for bipolar 1, where that's not necessary. So that's sort of what I've tried to indicate there by matching the colors. And cyclothymic disorder is sort of where you're fluctuating between hypomania and depression, but not really meeting the criteria for anything, but it's lasted for 2 years. So you're sort of just going up and down. But yeah, it's the 2 years that's really key with cyclothymia. So how I remember bipolar 1 is dig fast. So distractibility, increased elevated or expansive mood with increased energy, hyperactivity, motivation, or irritability. So with that, if for that one, it's only irritability that they have, like they don't have that expansive or elevated mood, then they need to have 4 of those symptoms rather than 3. So just keep remembering that. Grandiosity, flight of ideas. So they'll have pressured speech with that. A change in their appetite, which will usually be decreased. Reduced need for sleep, and socially disinhibited behavior. So risk-taking behavior that they don't usually do, like, drink driving, unprotected sexual intercourse, those sorts of things. And that'll sort of be indicators for that. Important to know about triggers for mania, because if you're in a setting where there's a manic patient in front of you, it's important to try and work out why this is happening. So often patients with bipolar have depressive symptoms much earlier in the course of their illness compared to their manic symptoms. So they're often put on antidepressants without, sort of being asked about those manic symptoms, and that can naturally precipitate mania. So that's important to remember. If they are already known to have this condition, but they're not compliant with their medications, stress, decreased sleep. And again, the decreased sleep could be a cause or an effect. So it's important to try and establish that, or using substances like stimulants. As far as the DSM-5 criteria goes, like we already talked about, should last for more than 7 days, should have more than 3 of the symptoms during that 7-day period. And it should lead to clinical impairment that's significant, or hospitalization. So the hospitalization is not compulsory, but the clinical impairment is not just mild. And yeah, again, like anything else, not due to a medical condition or substances. Differentials to think about is, is this depression rather than bipolar, like unipolar? Is it schizoaffective disorder again? So like we said with depression, you can have bipolar with psychotic features, but again, there won't be a period of time where the psychotic symptoms are present without the mood symptoms like they are in schizoaffective disorder. Schizoid or schizotypal personality disorders can present this way as well, but with personality, and another thing with personality disorders is they often have quite a long course, so they've been building up over time, and the person's usually had some of these traits for quite a long while, and they might have developed slightly earlier as well compared to bipolar, which usually is in the 20s or 30s when people are first diagnosed with that. ADHD is another one to think about, but again, that'll usually be in younger people, so that can be one way to differentiate that. So basically, if someone presents to you and they're acutely manic, you do a risk assessment, particularly focusing on their risk of harm to themselves or to others. And then based on that, you decide if you're in a regional hospital, whether they require transfer, or if you're in the community, whether they require a hospital admission, and that will be based on your risk assessment. It's really important to get a collateral history, because often manic people, or when people are in a state of mania, they won't really know what's happened or what's going on. So trying your best to do that is really important. Then as far as medication goes, acutely olanzapine is usually the second-gen antipsychotic of choice in that acute manic episode. But for the chronic management of bipolar 1, you use a mood stabilizer like lithium or valproate, but sometimes you can use quetiapine as well. So for those medications, know their side effects, and for lithium in particular, have some detailed understanding of how it works, why people are on it, and what the side effects can be and what the toxicity can do. It's quite a high yield topic. You can add on SSRIs, benzodiazepines. Benzos are not so commonly done, but you'll often see these patients on SSRIs. And I know I said earlier that that can precipitate mania, so they're monitored really carefully. The SSRI is always given in adjunct with their mood stabilizer, not by itself. And they're asked to report any symptoms immediately, so then you stop the SSRI. But often the patient population that has the SSRIs are the ones that experience the depressive symptoms of bipolar more than the manic symptoms. So if they have been on benzos, when you discharge them, if they've been in hospital, you sort of taper it off rather than cutting off the benzo straight away. And you make sure, and this is the same goes for depression actually, you make sure that they have a case manager, they're within the community mental health team, and they're actually supported in that regard. They have a regular GP that they see, and that's all really important for their ongoing care. They should also have a crisis plan, as well as patients with depression. So that should be something that they've established with either their psychiatrist or their caseworker, and essentially it's to detect their early warning signs and what they would do if they started seeing those signs, who they'd report to, or strategies they could have for themselves. If social work needs to be involved, they can. And as far as other chronic management, psychotherapy you can use. It's not as effective as it is in depression, but it's still an important part of the management. And sometimes you can use other anti-epileptics or clozapine or ECT as well, but again, not as commonly done. So I won't go through everything for bipolar 2, but I just want to highlight the differences between bipolar 1 and bipolar 2, because this can be confusing. So the main thing with bipolar 2 is it can often be likened to borderline personality disorder. And it's actually really tricky to try and separate out those two diagnoses, because in those episodes of hypomania, often the change has to last for 4 consecutive days, and that would probably be the main differentiating factor, because often with borderline personality disorder, which I think you're hearing about later today, the change changes that they experience can fluctuate quite quickly, like even within minutes or hours. So that would probably be your main indicator in terms of the difference. And again, like I said earlier, personality disorders take a longer time to develop and do have especially borderline risk factors such as previous trauma. So there'd be some ways in which you can differentiate the two. Again, bipolar 2 needs a 2-week depressive component, which isn't necessary for borderline. So that's another differentiator. And there should have never been a manic episode. So anytime someone has definitively been diagnosed with mania, it's definitely bipolar 1, not bipolar 2 or cyclothymia. Another thing with bipolar 2 is often the patient themselves doesn't know that this is happening to them because the change is so subtle. So it's observable by others and it's not severe enough naturally to cause clinical impairment, especially if they're not able to recognize it for themselves. So this is a tough diagnosis to make. Even psychiatrists struggle with this one. But, from an examination point of view, if you're asked about this, it'll be made clear that it's not mania. It's only lasted 4 days and they've definitely had depression for that 2-week period. It's best managed with sodium valproate. That's what the evidence says, but you have to be really careful in women of childbearing age, and they often do use other medications in that setting, but sodium valproate is the go-to. There are many women of childbearing age on sodium valproate, even though it's not ideal, but that's an extensive discussion that they've had with their psychiatrist. So really quickly on cyclothymia, needs to have lasted for 2 years, altering between hypomanic and depressive symptoms, but neither of those meet the criteria for mania or depression. Over that 2-year period, this needs to be present for at least half the time, and then not symptom-free for more than like 2 months at a time. So it's quite continuous. Research-wise, there aren't any medications that are specifically approved. Sometimes mood stabilizers can be used, but antidepressants are generally not recommended. So mood stabilizer would probably be the go-to here. But with cyclothymia, it's usually more about psychotherapy, such as CBT, rather than medical management. Often have comorbid ADHD, and given the nature of the condition, they're more likely to abuse substances, have difficulty with their day-to-day functions, such as work and relationships. And also it puts them at increased risk of then having a manic episode or a depressive episode and developing bipolar 1 or 2. Cool. So anxiety disorders. There's a few. Selective mutism, you probably don't need to know about. I think the name sort of says what it is, and just having it there as a differential is enough. We'll be going through those ones today. So in terms of the timeline, anxiety disorder is actually pretty easy because most of them just need to go for 6 months, except for a panic attack, which goes for minutes. So it's that sense of unease or apprehension that you feel about an impending event. And it's the reason why it's a problem is because it's excessive, it's persistent, and at times it can be irrational, and therefore it affects your day-to-day function. So the problem with anxiety disorders is they're actually quite highly prevalent. So 5% of the population, but only 1/3 seek help. And it usually always is related to some other type, like generalized anxiety disorder is always related to some other type of more specific anxiety disorder. So risk factors, again, similar to what we mentioned before, young adults, people who are middle-aged, like what we might refer to as a midlife crisis, females, having had a past traumatic event, so again, closely linked to PTSD, a family history, or a major change in circumstances that has then predisposed the patient to this condition, such as moving countries, for example. How I remember the history questions is B-SCIM, so blank thoughts, decreased energy, difficulty with sleep, that's both with onset and maintenance, being keyed up or on edge, so that's the being restless, irritability, and muscle tension. So because it's generalized anxiety disorder, this needs to be happening in more than one setting. So home, work, school, all need to be affected, or whatever other activities that are happening in your life. And it happens on more days than it doesn't and lasts for 6 months. It's really difficult to control. You need at least 3 or more of those B-SCIM symptoms. and it can be produced repeatedly when those situations in various aspects of your life occur again and again. So it's not a one-off thing. And the way in which people manage this anxiety is either by avoiding it or just putting up with it, or like asking others to help, which is common sense really, but it's a part of the criteria. Like anything else, impairs your normal function. But with all anxiety disorders, one of the criteria is always that the symptoms are in excessive to whatever the stimulus is that initiated that response. And again, not better explained by anything else. So ruling out organic things again, so cardiovascular causes. So, you know, we're thinking about things like, does this person have some kind of arrhythmia that's giving them palpitations that may be presenting as anxiety? Is there a metabolic cause? They're hyperglycemic, for example, or is this some kind of neurological problem? And medications like caffeine and alcohol, naturally. And there are a few investigations that you would consider doing depending on how the patient presented. The psychotherapy here is a little bit different, focused on like stress relief and stress management, because, you know, obviously being like restless and keyed up all the time is really taxing on the body. So things like relaxation therapy, problem solving therapy, are really good, and insight-oriented psychotherapy can be useful too. So usually insight-oriented psychotherapy is more used in conditions like schizophrenia or PTSD. But again, if someone has an understanding of why they're responding in the way that they do, it can help them manage that as well. So as far as medical management goes, only use benzos short-term, like for anything else, so just for crisis intervention. And with alprazolam, sometimes there'll be a variety of benzos you can choose from. If you're asked about this, avoid it because it has a high risk of dependence, and not many people respond to it. And generally, you should advise a patient who's on benzos to not operate machines, drives, because it's sedative, manual labor, or consume alcohol. Otherwise, mainstay, like most of the other things we've talked about, is SSRI, which is first line, SNRI is a second line, and then TCA and MAO inhibitors a third line. I think it's important to just know these as large categories rather than specific medications, because, you know, this year with OSCEs, you have your time to assess with the patient and then you'll get questions about it. So it's nice to have sort of different steps in your management. What would you do next if something doesn't work? And then we have panic attacks and panic disorder. So a panic attack is basically, it's sudden and there's intense fear or apprehension that something really bad is going to happen. And how you respond to that is essentially, it's an SNS overdrive, and that's that fight or flight response that you get. So it essentially peaks in the first 10 to 20 minutes. It can last for minutes to hours, but it resolves quickly when it does. And basically you need 4 or more physical or psychological symptoms, which we'll go through. But like we can see, the main triggers are increased work requirements, social breakdown, feeling like you're trapped, or, you know, you've been separated from something. So all things that would naturally make sense to make someone feel a little bit unsettled. But for these patients, they have panic attacks, which are a slightly more extreme response. And you'll note with psychiatry, a lot of these conditions, they are all things that we experience as normal human beings, just at a level that then impairs function. And that's how they're classified. So caffeine and nicotine can precipitate panic attacks as well as emotional disturbance, so anger or extreme sadness. And often it's nothing. So often you won't actually have a precipitant. So don't get hung up on the fact that, oh, I don't know why this person's having a panic attack. Sometimes they just happen. So that's a panic attack, just singular by itself. Panic disorder is where you have 2 or more panic attacks happening, but you have a month of anticipatory or avoidance behavior in between. So you're either really worried that it's going to happen again, or you know what caused it the first time, so you actively try and avoid that experience so it doesn't happen again, to the point where it's affecting your functioning. So again, these are quite common. 4% of the population Similar risk factors to before, but neglect and child abuse are quite common in this setting as risk factors. For the DSM-5, again, like we've said before, they need to be recurrent, the panic attacks, for it to be classified as panic disorder. At least one of the attacks need to have that 1 month period that I mentioned earlier. And again, it's not attributable to any medications, substance use, or any other physiological change caused by a medical condition or another mental health disorder. Yeah. Yeah, so the 1 month is the minimum rather than the maximum. Lots of differentials, again, just ruling them out systematically, going from organic down that pyramid earlier. Investigations, same thing really. Chest X-ray, because we're worried that is this an infective process that's sort of presenting as an SNS overdrive. So basically, in terms of management here, a lot of support is required from like friends or family or those that are like close to people. So CBT is actually really useful, but you can use medication. And again, it's the same sort of order: SSRI, SNRI, TCAs. Benzos only for acute relief, like we said. And sometimes you can add on an anti-epileptic, but that's often done with a psychiatrist. So just to know that that's an option. But the mainstay is antidepressants, really. So social anxiety disorder. So I won't read out all of this for each of them. The slides are here for you guys to read if you'd like. But essentially, it's a persistent fear of social performance in situations where you're in an unfamiliar environment or there's lots of people and you feel like you're going to be scrutinized by others. And the thing that they're scared about is that they'll act in a way that's really like embarrassing for themselves and will feel humiliated. So that's basically what it's about. And sometimes it can lead to panic attacks. So they are sort of interrelated. But the point is that the person actually realizes that this fear that they have is unreasonable. So they know that that's the case. But again, like everything else, there's that avoidance concept. They're not going to actively engage in situations that they think will put them in this position. And it should last 6 or more months. So all the criteria you can see is fairly similar across all the spectrum of anxiety disorders. It's just a little nuances about what it is. And it's often the title gives that away anyway. So I wouldn't stress too much. CBT is really the mainstay for this. Medications don't usually help, but if it gets to a point where it's really significantly functionally impairing, you could consider antidepressants. Benzos, again, in the short term, you wouldn't use that long term. But public speaking, or like if there's very specific short-term things that are causing social anxiety, like public speaking, you could consider a beta blocker, but not long-term. Separation anxiety disorder is more of a childhood condition. So you might have heard about it already in an earlier lecture. But basically, the anxiety comes from being separated either from home or like a person or people who you're really close with and have a strong emotional attachment with. But I think it's important to know it can affect adults as well, even though it's usually a kid condition. The thing with separation anxiety disorder is that it's developmentally inappropriate. So yes, sure, if like a 1-year-old had separation anxiety, that would be fine. And normal, it wouldn't be separation anxiety disorder, but so age is a big deal in this. And yeah, so again, lasts for 6 months, and I won't read it all out, it's all there, but the criteria are similar. I think the thing to know is like there's often refusal. So if they need to go to school or they need to go to work, they'll just come up with 100,000 excuses for saying why they can't do that, because they want to be in close contact with that particular person or environment. Again, CBT is mainstay for this. For kids, you can use family therapy or play therapy, and often that's quite nice. But if it's severe, fluoxetine is a consideration. Specific phobias are important. I think agoraphobia is the main one that comes up. So there's usually a bimodal age distribution. You either see it in kids or in mid-adulthood. But just important to know that between the age of 8 months and 4 years, you can actually have specific, like be phobic of something, but it's not a problem. It's actually physiologically normal in that period. Risk factors have, if you had panic attacks, you know, you might have like a phobia to whatever triggered that panic attack or any other past traumatic events. Ruling out organic causes, so particularly not to forget, so if they have an arrhythmia, that's important, might need urgent management, anaphylaxis or a foreign body or a thyrotoxic storm. So these are all sort of ED presentations, so it'll be important to rule them out. Similar criteria, you have marked anxiety or fear, but this time it's about a specific object or situation rather than what we said earlier about generalized anxiety disorder. Again, it's repeatable, it's out of proportion to what you would expect, so it's unreasonable in that regard. More than 6 months, impairs normal function, and not better explained by anything else. And again, like everything else, psychotherapy, SSRI. So I'm sure everyone's seeing a pattern here, and it really is a bit like that. So what you really need to know is what the definition is, or like what it's describing, and the DSM criteria and how it's different to other disorders that fall within that same spectrum. Agoraphobia is just a specific fear of public places, but it's based on the fact that it might be difficult to then get to a safe place. So these people often describe a feeling of being trapped, and therefore they like stay at home or stay wherever they're comfortable. And it could also be secondary to a panic disorder. So similar sort of DSM criteria, but a few more psychotherapy techniques we can try. So graduated exposure therapy. So, you know, maybe they can like go out with someone first or go to the post box and back and sort of build up from there. And sometimes building social skills is useful in this situation too. And yeah, insight-oriented psychotherapy is used sometimes as well. Medication, same thing. SSRI, if you need, most people don't need it. And then follow on the same medical management as we've said for most of the other anxiety disorders. So, OCD. Again, a few different conditions, but we won't go through all of them because they don't necessarily come up that much. And the bottom three are basically evident in the title itself. So we'll go through OCD and body dysmorphic disorder. Trichotillomania is pulling out hair. Excoriation is just scratching at yourself. And the criteria is the same. That's just what they ask. That's all you need to know about them, really. So OCD, what's an obsession? It's when you're persistently overwhelmed by recurrent and unwanted thoughts that you know are false. And a compulsion is a repeated ritualistic behavior you feel compelled to perform to avoid either ongoing anxiety or a dreaded outcome. So there's some classic examples for this, like you park your car and you pay for it and you get your ticket and then you start walking away, but you know, you keep thinking, oh, did I get a ticket? Did I not? Like, did I pay for the ticket? Did I not pay for the ticket? Like, you know you did, but you're just constantly worried about it. So then you'll go back to your car and you'll check and you'll come back. And, you know, every time you're in that situation, you always do that. Or the other classic example is hand washing. Like, you know, you've examined a patient and you've gone and washed your hands, but then you're persistently worried that, you know, oh, what if I didn't do it properly? You know, what if like anything? And then you go back and just keep washing your hands over and over again. And just an important point with that is that often the patients in that situation who do hand washing a lot present with contact dermatitis. So with the psychiatric OSCEs, your patient presentation might not always be a psychiatric condition. Like, they might not present being manic or depressed. They might actually present with another medical symptom like contact dermatitis or, you know, a burn or a cut, and then you have to go from there. So that's just an important one to keep in mind for this. And like you've probably already read by now, there's a few disorders that fit under the OCD category. It's the fourth most common psychiatric disorder, so highly examinable, but also really important to know about for life in general. Most of these patients have comorbid major depressive disorder or a social phobia. So you can see these are all linked to each other. And I've got some of the common obsessions and compulsions there. Basically, they need to be time consuming. That's what makes them fit the criteria. Like everyone's got some level of making sure things are done properly, but if it's taking more than 1 hour per day or causing clinically significant distress or impairment that's preventing from, meeting their usual functional needs, then it would classify as OCD. Again, not due to anything else, not due to physiological disturbance. Some differentials, there's a few sort of things like Huntington's and Sydenham's chorea that don't come up elsewhere that are a differential for OCD, so they're worth remembering. But yeah, OCPD, obsessive compulsive personality disorder, is also another important differential for OCD. Thing with OCPD, the main difference is that individuals who have obsessive compulsive personality disorder are more likely to actually not enjoy but be comfortable with having those obsessions and compulsions compared to someone with OCD who absolutely hates it and just wants to get rid of it. So like it's that ego-syntonic, ego-dystonic sort of description that difference that we're looking at. So as far as management goes, psychotherapy is probably the main thing, especially if their OCD has been precipitated by a traumatic event, but also graduated exposure therapy in this setting is particularly important. So I would focus on those, but you can use medications and it's the same order as before, SSRI, SNRI, TCA. And then if it's resistant to all those antidepressants, you'd consider a second generation antipsychotic, but I haven't personally seen that be used and it's not very common. In terms of prognosis, it can go either way, but if they have a good level of social support and don't have any other mental health problems, they're actually quite likely to do pretty well in that regard. So yeah, I have written what those are and what you need to know about them, but again, not extensive. Don't worry about learning the DSM criteria for those conditions, just know what they are. Cool. So, PTSD. I won't talk about all of them. Hopefully you did reactive attachment disorder a little bit earlier today, but you've got acute stress disorder, PTSD, and adjustment disorder. So they're your sort of timelines. Acute stress disorder is the 3 days to 1 month, PTSD is 1 month or more, and then adjustment disorders. So it starts within 3 months of whatever triggered it, and then it can go on for up to 6 months, and then after 6 months, it's depression. So acute stress disorder is basically this really intense, unpleasant, dysfunctional reaction that you have that starts pretty much after a traumatic event straight away, and it lasts less than a month. So it's got similar DSM criteria to PTSD. So again, it could have been a situation with actual or threatened death, serious injury, sexual violation, and that can be either because you directly experienced it, you witnessed it, or you heard about it, or for some reason you've been repeatedly exposed to it. So we'll go on to PTSD. Sorry, I should have maybe had that first, but you need more than 9 symptoms from various categories. So that's intrusive symptoms, negative symptoms, cognitive, avoidant, and arousal-based symptoms, which I'll show you in a second. But essentially the mainstay here is CBT. Because it only lasts for a month, you can consider benzotherapy because it is short term. But yeah, don't use that for more than 2 to 4 weeks. And, I've seen that sometimes to be quite excessive too. So, and then taper the benzo gradually after that period. But acute stress disorder can then progress on to become PTSD if it lasts for longer than a month. So I'll do PTSD first, actually. So we've all heard about this, and we know of the common risk factors. So really important to include these in a comprehensive history when you're suspecting someone might have a diagnosis of PTSD. So yeah, returned servicemen, really young people who've been exposed to a traumatic event, or really elderly because their coping mechanisms are either immature or rigid based on their age. Their social circumstance can affect their likelihood of developing it, as well as having a family history of PTSD, being male or having poor family support, and domestic violence, sexual abuse, and other traumatic events as such, natural disasters, all risk factors. So just having that sort of broad mindset of what could have caused this. Basically why it happens is because if you have a repeated exposure or repeatedly think about it, it's essentially classical conditioning, and what happens is the same sort of response that you had when you were in that situation, you'll get outside of that situation because you're classically conditioned to react in that manner. And it's often linked with a sensory stimuli. So the symptoms, like we were saying before, the intrusive symptoms are nightmares and flashbacks. And the negative or cognitive symptoms are having gaps in your memory or negative self-emotion. So each one's your separate: fear, guilt, horror, anger, shame, or apathy. Avoiding triggers. So that can be internal or external triggers. So external triggers will actually be environmental things. So say, for example, you had a really bad car accident on a particular road, and that was quite a traumatic experience, then you would actively try and avoid that, either internally by just not driving in general because it's freaking you out, or externally just by avoiding that particular like road or intersection where that accident happened. Hyperarousal is the last sort of category, and that's all your SNS symptoms. So look up the criteria for this because not all the SNS symptoms are listed in that fourth category, but yeah, you need 9 out of all those ones to have it. And yeah, it's often comorbid with depression, anxiety, and particularly substance use. So another thing is often when like a patient like this will present to you, like, yes, they'll have PTSD, but it's really important to make sure that they don't have another one of these conditions that's actually more of a problem at the minute than their PTSD. Like, are they, for example, abusing drugs or drinking too much alcohol, and that's what's their current issue rather than their PTSD, and that's actually just their background condition. So just keep an open mind about that as it comes to exams. DSM-5 criteria, like we said before, you need pretty much more than 1 in each category, and that's how you sort of make the 5. So you'll need more than 1 in one of these and at least 1 in all the others. Impacts your psychosocial function, needs to be present for at least a month, because if it's not, it's acute stress disorder. You always need to do a risk assessment for these patients, like any other patients, but particularly important if you're suspecting PTSD, particularly for suicide and self-harm risk. But again, ruling out organic causes. Same sort of lifestyle management, but focusing particularly on managing any substance abuse, and psychotherapy, systematic desensitization, and eye movement desensitization and reprocessing therapy are specific to PTSD, but you can also use other relaxation techniques like breathing, progressive muscle relaxation, and that sort of thing. And for pharmacotherapy, SSRIs, but it's mainly focused on psychotherapy. Prognosis, 1/3 get worse, 1/3 stay the same, 1/3 get better. Cool, so we're up to question. Oh, sorry, I'll just go back. We'll do adjustment disorder. So adjustment disorder is basically a short-term condition that happens when the person has difficulty coping with or adjusting to a particular stressful situation that's happened, and that's usually a major life event. So it's different because there could have been a trigger, and then within 3 months of that trigger, the patient starts developing symptoms, and the symptoms are basically marked distress that's out of proportion to the intensity of the original stressor, and it causes a significant impairment in their function. And then it should resolve by 6 months. If it doesn't, it's then you check if it meets the criteria for major depressive disorder, and if it does, adjustment disorder usually progresses on to major depressive disorder. So 6 months from when, you start getting the symptoms within that 3-month period, the symptoms should have resolved by that point. But yeah, that's probably the only main things to know about adjustment disorder. Same sort of differentials. Is this a dementia? Is there actually some kind of anatomical variation in the brain? Is it MS, Parkinson's, or is it another psychiatric condition like bipolar? Or is this just a normal grief response? So, if someone passes away, it's natural to feel sad about that for a particular period of time, but, working out is this gone on for too long and are the symptoms too excessive of what you would expect in that situation? Generally, because it only lasts for such a short period of time, we don't use an SSRI. It's not actually going to reach its therapeutic effect within that period, and they don't require it long term. So even if it does, you'd pretty much have to stop it straight away, which is not worth it for the patient. But they can use benzos PRN, again, because it's quite a short-term time frame. But supportive therapy really is mainstay, along with some CBT. Okay, cool. I'll read out the question. I'll get someone to yell out the answer. So a 20-year-old woman complains of insomnia, finding that it takes her 1 to 2 hours to fall asleep. She ruminates about events of the day and worries about the challenges of tomorrow. She asks you if a sleeping tablet might help. Okay, who thinks a sleeping tablet might help? Okay, I'll reword that. Who thinks who would prescribe a sleeping tablet to her? Okay, good. So if we're not prescribing a sleeping tablet, what are we going to do? I heard a CBT. Any other ideas? Yeah, so really this question was tossing up between CBT and sleep hygiene and what's most appropriate. So I find often with these questions, it's actually about going systematically and being like, what would you try first? It's definitely not wrong to try CBT. It would be helpful, but you'd probably make sure that she actually had proper sleep hygiene first. And if she did, you'd then go on to CBT. And then, you know, if it was a problem further, you'd actually ask other questions and try and work out, is this some other condition like depression, and then treat that accordingly. But yeah, first step would be to discuss sleep hygiene. Cool. So Fahim is an 18-year-old who just received a scholarship to study overseas in 6 months' time. She's never flown in a plane and she's really anxious about the prospect of that. And she hasn't been able to sleep over the thought of being in a plane, let alone flying overseas in one. Yeah. Okay. So, with this one, I guess the toss-up really is: do you give her a benzo to help her with her anxiety, or do you try something else? So, if this would have said she needs to go overseas tomorrow, yes, you would give her a benzo. But it's in 6 months' time, so you could actually try and desensitize her through graduated exposure therapy. You know, maybe take her to an airport first, then make her sit in her plane. And then eventually when she needs to fly, she'll be a bit more okay with it. But yes, if it said tomorrow, you would use a benzo. Cool. So Sam is a 19-year-old with a past history of being bullied at school. This resolved when she was able to complete her secondary schooling by distance education. She doesn't have friends outside her immediate family, and she's found it difficult to settle into university life. She feels really anxious when she has to catch public transport and in lecture theatres, and she avoids making eye contact with anyone, and she can barely answer if anyone speaks to her. So I'll just ask you guys, what's the diagnosis? Awesome. And what do we do for social anxiety? Yep, so psychoeducation could be an option. CBT, I'm hearing. Yeah, so look, this one's tricky, but you'd always start with CBT. If her functional impairment was so severe, so if this said that, you know, she's doing schooling by distance education, so she feels anxious when she has to catch public transport, but she's still doing it. She has trouble in lecture theatres, but she's still going there. If she wasn't doing any of that stuff, you'd think about an SSRI, but because she's still doing it and she's struggling with it, you'd probably do CBT first. So these questions are all a bit tricky and difficult sometimes, but these are sort of general consensus answers. Last question. 29-year-old secretary presents with acute episodes of anxiety, generally waking her from sleep. She says like she feels like she's drowning at these times. Her workplace is undergoing restructuring, and she thought she was coping with this as she'd been under no more stress than usual during the day. So crisis intervention is an interesting one. So often crisis intervention is used in a situation where someone is at risk or about to do something that's really risky, but they're not at a point where you would consider hospital admission. So if someone is acutely suicidal and you end up at their, like, they call you or you end up at their house and you find that, you know, they've hung a rope on their garage and they're about to hang themselves. Yes, you admit them to hospital. But if you get to their house and they say, oh, I've been planning this, I've been thinking about it, that's where crisis intervention comes in. So it's a little bit tricky. You use crisis intervention in an acute risk situation that you think doesn't require immediate hospitalization. So this one's tricky because she's waking up at night and, like, you know, she's feeling quite crappy at those times. So you'd wonder if maybe she needs some medication to help with it. I guess the consensus is you'd always still start with CBT and see how she goes. And based on that, you might need medication. But this is a very 50-50 sort of question. It wouldn't be wrong to say medication in this context, but you'd always try CBT first. Yeah, so with this question, with this particular question, again, it was tricky because there was no sort of general consensus diagnosis that anyone could come to. It could be some state of panic. That might be what's going on. So not particularly panic attacks, but they could be contributing. Could be more of a generalized anxiety disorder that's presenting this way. But given that she's fine during the day and just happens at night, you wonder if, you know, is there some sort of traumatic component to it too? So there's no particular definitive diagnosis for this one. So it's more just general, what would you do to help with this situation? Sorry, I just put some of the questions that are a little bit more challenging to come to a definitive answer in here. But I think the principle really is, what would you do first? What's your first line therapy? What would you try? And then what would you do consequently after that? Or if the situation is really significant, severe, or extreme, then maybe you would jump straight to one of the medical options. Cool. And this is how you might be feeling right now, but there is light at the end of the tunnel. You guys will be fine.